Good morning, everyone. Welcome back to the FHS seminars. Please help me welcome our speaker for the day, Dr. Sara Bennett, who is a professor and associate chair in the International Health Department of the Johns Hopkins Bloomberg School of Public Health, where she also serves as the director of the Health Systems Program. She was recently appointed faculty co-chair of the Gupta-Klinsky India Institute, which is an initiative that mobilizes faculty and students across the university together with local partners to improve Indian society. Her areas of expertise include health workforce issues, health financing, health markets and development partners practices, low and middle income countries. Dr. Bennett's research has had a significant impact on the development of the field, and she has made important contributions to the institutional capacity development, to health system governance, and the use of evidence in policy and decision-making. Dr. Bennett's dedication to bridging the gap between academia and practice, as well as building institutional capacity for health research internationally, is evident in her strong commitment to making a real-world impact. Her talk today is entitled, "What Have We Learned from the COVID-19 to Ensure a Stronger Health System?" She will go over the lessons that can be drawn from the COVID-19 experience. So the talk will take around 40 to 45 minutes. We'll leave the remaining time for the Q&A. So Dr. Bennett, thank you for accepting our invitation, and the floor is all yours.
Thank you very much indeed, and thank you also for having me here. Can you hear okay in terms of the volume? Good. I'm going to just get out my phone so that I don't run too late and make sure that I stay on time. There we go. As has just been said, I had wanted to reflect today on what could we learn from the past 3 or 4 years of COVID-19. And it feels now that we're at a point where we're beginning to come out of the acute phase of the pandemic. People are beginning to circulate. I'm beginning to travel again. And it seems like it's a good point at which to take stock of what has gone on over the past few years. Thank you. So I guess the premise for what I had wanted to say is that I feel like COVID-19 has stressed health systems across the world in at least 3 different ways. So firstly, health systems were required to mount a public health response, including things like testing, diagnosis, surveillance, risk communication, restrictions on social movement. So all of the things that were part of that public health response. At the same time, there was obviously a really increased burden of disease from COVID-19 itself, and this challenged health systems to organize testing for COVID-19, diagnosis, often setting aside separate treatment areas and facilities, mobilizing additional bed capacity for COVID-19, and making sure that adequate supplies were in place, whether we're talking about oxygen and personal protective equipment. And then thirdly, on top of all of that, besides dealing with the direct consequences of the pandemic, health systems also had to figure out, well, how do we maintain the regular flow of services that we provide under these very difficult conditions? And so we've seen across the globe adaptations to facilities and the services they offer, the delivery models that they employ in order to try and increase infection prevention controls and separate COVID from non-COVID patients. Next slide, please. So in putting this brief presentation together, I've really tried to address 3 questions. Firstly, what were the characteristics of effective health systems during the COVID-19 pandemic? And secondly, what have we learned about how health systems need to be better prepared for pandemics in the future, knowing that there are likely to be future pandemics? And thirdly, what of the sort of characteristics of the response that we've seen in health systems are going to be useful outside of regular pandemic periods? Have we seen innovations that are more broadly helpful in terms of health systems? Thank you. And I'm going to sort of start with previewing the three themes that I had wanted to focus on. Firstly, I think that systems that responded to the pandemic best tend to work in a multisectoral or whole of society kind of fashion. They included strong governance and leadership, and they are often collaboration with the private sector. And I think that those were achievements in some ways during the pandemic that need to be sustained going forward. Secondly, I think one of the things that the pandemic revealed to us was how weak the public health system is in many countries across the world, high income, low middle income countries. And as someone who's worked for their entire life in the sort of field of health systems and health system strengthening, one of my reflections is that we have really, as a community, neglected public health systems, what they should look like, how they should be organized. So I'm going to expand on that. And then the final theme that I'm going to be talking about is the fact that COVID-19 prompted a lot of innovation in terms of how services were provided. And I've given you some quick examples here, notably the spread of mHealth and the use of technologies for delivering care, issues around patient stratification, particularly for NCDs, drone delivery of supplies we've seen in some cases. So I think we need to take stock of how effective some of those innovations were, and can they be incorporated into health systems going forward. So those are these are the three main themes that I'm going to use for the bulk of the presentation. I wanted to talk briefly about methods and approaches. So next slide. This presentation is drawing upon several different studies that I've been involved with, and I'm not going to go into a lot of detail in each of them, but just to give you a broad sense of what they are. One is this exemplars in global health. And I've been involved with colleagues from Brown University, particularly Jennifer Nuzzo, in terms of understanding what were the characteristics of health systems that allowed them to be resilient during the pandemic, and in particular, maintain delivery of essential health services during the pandemic. This we have done in collaboration with 6 different countries, and I've listed here the different countries that we've been working in: Costa Rica, Dominican Republic, so 2 in Latin America, Ghana, Uganda in Africa, Sri Lanka and Thailand in Asia. It's a Rockefeller and Gates Foundation funded study. And in the first phase, we looked internationally, only at low and middle income countries, to try and understand which countries have both experienced some sort of outbreaks during the pandemic, but also managed to maintain and sustain essential services. That was actually really challenging to do because there's not a lot of evidence about essential services and how they were maintained. But based upon that, as well as some semi-structured interviews, we selected these 6 country cases and then commissioned country case studies that used a collation and analysis of existing data, as well as document review and semi-structured interviews. The second study that I'm drawing upon is sort of long-standing work that we have had in the state of Uttar Pradesh in India, which is a large state. There's more than 250 million in that one state alone. It offers, I think, a number of different lessons. And as part of our long-standing work there, we both conducted a case study of how the state had responded to the first wave of COVID-19, working with a colleague, Brian Wall, who led that work. And then I had a supplementary grant from Johns Hopkins, which was trying to focus in particular on the role of the private sector in Uttar Pradesh and how they had been involved in the COVID-19 response. And again, you can see the methods here: document review, media analysis we did for this as well, and semi-structured interviews. Then the final sort of piece of work that I'm drawing upon comes from a grant that we have about building stronger national public health institutes that is supported by the US Centers for Disease Control. And what we've been trying to do under this grant is work with our colleagues in the CDC and the US CDC to help them then serve and build capacity at these national public health institutes. So I'm not sure what the situation is here in Lebanon, and I'd be interested to hear. But I think in many contexts, country governments are establishing national public health institutes with a primary responsibility for public health. And they look, somewhat similar to the US CDC with sort of similar sets of functions. We've been working sort of internationally, interviewing leadership of new national public health institutes, and also with direct engagements for system strengthening in the 4 countries that I've listed here: Republic of Georgia, Liberia, Sierra Leone, and Zambia. And so much of the sort of what the methods we've been using here are both document review, but also participatory workshops with NPHI staff. So I wanted to talk a little bit about what were the characteristics in terms of health system characteristics of an effective response to COVID-19. And this is drawing very much from the exemplars in global health work. And we've split it out into 2 levels: what was going on at the sort of national population level, and what was going on more at the sort of service delivery and community level. And I think looking at the 6 country case studies that we had, there are a number of things that stood out to us. So firstly, early and effective outbreak control and case management to suppress COVID-19 transmission and minimize disruption to essential health services. So those countries that were able to sustain essential health services, particularly in the short term, were ones which took early and fairly strong population health measures to prevent the spread of COVID-19, which I think is hardly surprising. The second point, and I already flagged this as something that I was going to speak more about, is a whole of government response with strong multisectoral collaboration and early establishment of national decision-making bodies to drive the COVID-19 response. And I'm going to talk more about that, as well as about this third point, which was effective public-private partnerships, including strong academic government collaborations to facilitate data-driven decision-making. Other things that we found in terms of what worked at the sort of national and population level included government policies put in place expressly to protect essential health services during COVID-19. So those countries which acknowledged that COVID-19 was likely to have an impact upon their ability to sustain essential health services, such as immunization, keeping people with non-communicable chronic diseases on medications, for example, and explicitly said, these are the services that we want to maintain during the pandemic, tended to have greater success than those that really didn't sort of have clear-cut policies around that. And then finally, we found also that flexible health financing mechanisms to support the emergency response were key. So there's countries that tended to do well in terms of maintaining essential health services were ones which were often well positioned in terms of universal health coverage, had mechanisms in place to provide universal access to the population. And in some cases, like we worked in the Dominican Republic, where they didn't have a sort of a system or a structure for universal health coverage in place, but the COVID-19 actually proved a prompt for them to get that into place. And also some countries like Costa Rica had a specific sort of precautionary fund, which they dipped into in order to be able to provide a COVID-19 response. Then moving down and sort of thinking about the same set of questions at the service delivery or facility level, we saw a lot of adaptations happen there. And certainly these service delivery adaptations and provision of care through alternative means helped to minimize the disruption that COVID-19 created. Also, aggressive vaccination efforts to reduce the burden on the health system of COVID-19 was another characteristic of sort of what went on in terms of successful countries. And then rapid mobilization and deployment of health workers. So in many of the countries that we selected as having kind of a successful response to COVID-19 and being able to sustain essential health services, they had really very integrated health systems, and they had data from across the country on where health workers were, on where COVID-19 cases were. And so they were able to move health workers from one geographic jurisdiction to another to reflect, where the greatest demand was. And they also were able to move patients, resources, and supplies across the country. So places like Costa Rica, for example, managed that very effectively, sort of targeting where the outbreaks were greatest. We also saw adaptation of infrastructure and disease response capacities. So we saw shifts in terms of lab networks and surveillance systems to try and manage the response. So that's a sort of high-level overview of what came out of the exemplars in global health study around what it took to sustain essential health services during the pandemic. I'm now going to dig into three areas in more detail. And the first of them is this whole of society approach. So first of all, to sort of characterize what we meant by a whole of society approach. Firstly, it was a whole of government response. So there was early and planned multisectoral collaboration involving both health and non-health agencies, and early establishment of national decision-making bodies, which were often championed by very senior level government leaders, not just the Minister of Health, often going to prime ministers or presidents, which enabled swift action and sort of coordinated policy decisions. They also put processes in place for rapid multisectoral and multi-institutional decision-making and coordinated response efforts, taking into account not just health issues, but economic, political, and social impacts of the pandemic. And then countries which did well in this regard also paid attention to the emerging evidence base. And casting your minds back to 2020, we had such little knowledge in the early phases of the pandemic about what was successful and what was not successful. So, and what we knew about COVID-19. So the ability of these government entities to work closely with research in the university sector was also a characteristic of a successful response. So to give you some examples of this, and you're probably aware that India's second phase response to the second phase of the pandemic, the sort of Delta phase, was actually a very bumpy ride. But in Uttar Pradesh, the first phase actually was relatively successful. And these were some of the sort of details about what actually happened there, speaking to some of the things that I've just said. So there was early recognition that a multisectoral approach was necessary, and the chief minister, who's the sort of head of state in the state, constituted what was known as the Team 11 early in the response, 25th of March 2020, and it involved all senior bureaucrats across multiple government agencies in the state. They established a control room and 10 different teams within the Ministry of Health and Family Welfare, even earlier in March. And then they also mounted these kind of multisectoral teams within each of the districts to manage implementation. And they shifted to an integrated command and control center rather than sort of working through department-specific centers. There was also a mixture of top-down leadership and decentralization. So the Chief Minister's office hosted daily meetings with Team 11, and his office also monitored all of the activities going on. And he went out of his way to make himself reachable to local bureaucrats, saying, I want to hear from district staff about what's going on the ground. I need that kind of on-the-ground input about what's happening. At the same time, the district magistrates, who are like the head of districts in the state, were empowered to oversee implementation and integrated COVID command and control centers in the districts. I would say that in the second phase of the response in Uttar Pradesh, there was even greater decentralization down to the districts, and the district magistrates and the chief medical officers in each district were further empowered. But some of these coordinated approaches were really eroded, and they sort of went into a panic mode. I think the hospitals got so overwhelmed that there was a less sort of rational approach to decision making. I'd also said that one of the things that characterized this kind of whole of society approach was much greater engagement of the private sector. And we see this in UP, and I'm going to talk through this slide in a minute, but we saw it across the 6 countries in the Global Health Exemplars project as well. So in UP, the government of UP's approach to engaging the private sector, first, it had very strong engagement with laboratories and private laboratories and diagnostic centers within the state. When COVID first started, there was a very limited number of government testing capacity, testing facilities for COVID-19. I can't remember the exact number, but I would have said probably less than 10 for a population of like 250 million. So they ramped up both the government facilities, but they also put contracts in place with a large number of private facilities who they very rapidly accredited and said, you've got the standards in place to be able to provide testing, and then we will will accredit you as a private testing lab. And that meant that those private testing facilities could test and charge patients, or if they were testing patients who had the government insurance scheme, something called PMJ, they could also charge the insurance scheme for those tests. In terms of hospitals and nursing homes, so initially the government thought that they wanted to use primarily government hospitals, and they designated certain government hospitals as COVID centers. And so patients were meant to be taken to those COVID centers, and then they prepared the private sector hospitals as backup. If we run out of space in the government centers, and then people will be taken to the private centers. That was what happened during the first phase. As I said, during the second wave, which was April 2021, when I suspect the mass media across the world was full of the sort of the very dire effects of the Delta wave in India, actually those private hospitals became a very integral part of the response, and government insurance schemes were paying for services from those private hospitals. In terms of single doctor clinics, the government was a little bit more cautious about engaging those single private doctor clinics, saying that, you know, we're not sure that they really have the capacity. So initially, they actually shut down those outpatient clinics. And later, once they were in the sort of first phase of COVID-19, and later when they reopened, they were seen as referral units. So private doctor clinics were meant to be referring patients to the government hospitals. And then one interesting thing that we found was these rural medical practitioners. So in India, there's a very large number of unqualified private doctors who provide services. And the government refused to coordinate or collaborate with those doctors, despite the fact that they actually provide essential services, particularly for the poor in India. So in terms of sort of barriers and facilitators to working with the private sector, we saw barriers because private providers were often really scared about the implications of working during the pandemic and what happened if they contracted COVID-19. And one of the facilitators here was a national government scheme that was designed to provide life insurance to any health worker who was working during the pandemic, whether it be in the public and private sector, although we also found that it was actually very difficult to access. We also found barriers in terms of ad hoc communication. So, you know, the pandemic forced the government to bring in a lot of private sector providers, but they didn't have established communication networks for how they worked with those private providers. To a certain extent, provider associations, sort of, you know, medical associations, nursing associations became the intermediaries. But a lot of what was going on was informal WhatsApp messaging. So most of the sort of government policies went out via WhatsApp. Another barrier which private providers reported was a lot of burdensome reporting requirements. And there were a number of different apps and sort of online platforms for reporting COVID-19 and COVID-19 outcomes. And over time, those improved, but certainly during the early phases, they were very cumbersome. And then another thing which the private providers saw as a barrier was that government capped lots of their prices. So they said, you can't charge more than this for testing, you can't charge more than this for an inpatient day. And private providers said, well, this is all well and good. We see that it improves access for the patients, but our costs have gone through the roof because everything is in short supply, and this is really eroding our profits. So I also wanted to reflect a little bit on evidence, information, and disinformation, because I said one of the things that sort of a hallmark of a successful response and this sort of whole of government, whole of society approach was a willingness of government to work with universities, to work with research institutes. And in UP, Uttar Pradesh, this was not really what happened. We found there was daily reporting of COVID numbers, but there has been a lot of questioning about those numbers and whether they're accurate or not, and some evidence that the Indian government at multiple levels put pressure on providers not to fully report. We also realized that there was a lack of learning over time. So we did sort of different rounds of data collection in this context and realized that when it came to the Delta wave in April 2021, there was a lot that the government should have learned from the previous wave, as well as from the Delta wave in Europe, which they hadn't done. And the second wave was characterized by a lot of reliance upon social media, particularly amongst community members and these informal doctors. And that went along with a lot of misinformation. And there was no government strategy to really address misinformation. By contrast, some of our exemplar countries had really built successful collaborations between government and universities, with sort of university researchers sitting in some of those sort of multisectoral meetings, providing evidence to help governments decide what to do. And we also found in some cases concerted efforts to empower healthcare workers so that they were able to address misinformation within their community. And Sri Lanka was one example of this. So in terms of implications for strengthening health systems in the future, I think there are questions about the fact that COVID-19 really brought in the highest level politicians to public health. And how do we sustain that going forward? How do we sustain that kind of interest from very senior politicians? I've noted that more successful countries were able to align decision-making with the available evidence base. And I think that we need to think more about how do we train public health practitioners to navigate complicated political environments. This is particularly an observation actually from the US, where I think in many cases, public health professionals did not do a good job at realizing how politicized decision-making was around COVID-19 and figuring out how to navigate that. But also this issue of how do we empower public health workers to address the spread of misinformation, which became, I think, a major problem during COVID-19, as well as strengthening academic and government ties. And then I've described how in Uttar Pradesh, at least, there was extensive and really quite unusual collaboration between the public and private sectors. And in contexts such as India, and I know this is somewhat true in Lebanon as well, there's a very robust and vibrant private sector. In India, it's largely ignored by government. So thinking through, how can we sustain this greater public-private coordination in the future? So I'm going to move on to the second theme. I've talked a little bit about whole of government, whole of society approaches. Now I want to talk briefly about public health and building standards and systems for public health. So I've already said that some of the countries that were most successful in terms of addressing COVID-19 and sustaining essential health services acted early and aggressively to limit the spread of COVID-19, and that infection control helped them sort of buy time to build health systems capacity. And those countries that were successful in this regard often had prior experience of managing epidemics, so Thailand being one example, and/or they had very strong government public health system capacity. So through this work we've been doing with the US CDC and national public health institutes across the world, we've recognized some number of sort of challenges that public health systems often face in terms of disease surveillance and response to epidemics. This slide sort of identifies those. So firstly, in many cases, it seems like the public health system exists more at the national level, but has very weak linkages to what's going on in the community level. And I'll talk more about this. And also many of these national public health institutes have been carved out of ministries of health. So countries have taken a sort of communicable disease unit in a ministry of health and established a separate National Public Health Institute, but they haven't thought through clearly how do these new national public health institutes interact with the regular health system. There's also often frequently multiple different disease reporting systems that has led to fragmentation and duplication. And so this is an example taken from Zambia and the National Public Health Institute there, who we've been working with. And we were trying to work with them to draw process maps of how disease outbreaks get reported to them. And what they told us is, well, there's actually 3 different disease reporting systems. One for all the vertical programs, malaria, HIV, TB, all get reported to vertical programs. There's then the Ministry of Health channel, and then there's the National Public Health Institute, the public health channel. And then at the community level, they noted that, the Ministry of Health has paid health assistants there who are meant to be reporting communicable diseases to the Ministry of Health. but the National Public Health Institute is reliant upon unpaid volunteers at that level. So all of the stars that sort of indicate the challenges that they identified across their disease surveillance and reporting systems, and in particular sort of role confusion about how these systems operate. The other thing that we found in many contexts is staffing limitations, particularly in surveillance and response teams. And during the pandemic, those teams were often supplemented, hiring new people, but often those new recruits had limited training, and so sort of concerns about the overall public health workforce. I think I'm going to skip through this slide in the interest of time. It's just really looking at some of the barriers and facilitators to operationalizing public health plans. And I would note that a lot of these were sort of political in nature. They saw political momentum as being important to being able to operationalize public health plans, but they also saw it as a barrier, meaning that that political commitment to public health often wasn't there until COVID occurred. And COVID sort of helped to galvanize some of that commitment to public health. But the question, I think, is whether it will be sustained going forward. So in terms of implications for building stronger public health systems, and this is a picture just of some of our team in front of the National Public Health Institute of Liberia, MPhil at the top. I think it seems obvious and logical that greater investment in public health systems is needed. As I said already, I think many countries are now establishing these new institutions, but if we don't go make very clear efforts to identify their mission, their mandate, how they function, what structures they operate through, then these may just add to some of the confusion that already exists. And then I think we've been talking about integrated disease surveillance and response for many years. It's sort of actually been on the sort of global agenda since 1998. People have talked about integrated disease surveillance and response, but in reality, surveillance often remains highly fragmented and with a lot of confusion around those reporting systems. And often that's donor-driven, particularly in sort of lower income countries. Development partners have tried to sustain systems for the particular diseases that they are interested in, which I think has got real sort of problematic consequences. The other domain that I would like to sort of pull out in particular, and maybe this is especially relevant to a public health training context, is around the public health workforce needs going forward. So we've been working with both Liberia and the Republic of Georgia to try and think about their public health workforce needs. And there are really basic things like agreement in terms of who constitutes the public health workforce. WHO talks about the core public health workforce, those people who do epidemiology, outbreak control, response on a sort of day-to-day basis. But then there's also people in ministries of health who have a sort of public health element to what they do. And then there's also people in ministries of agriculture, wildlife, other sectors who have some linkages into public health. And so trying to think more holistically about who is that public health workforce, what their roles are, is really key. In most instances, we've realized that it's not possible to get any sort of reliable data about who the public health workforce is. Most countries don't have human resource information systems that capture the public health workforce or tag them as public health workers. There's often not established competences for the public health workforce in a particular country, let alone job profiles and measures of sort of assessing their performance. And then in order to address some of these sort of systematic or systemic and structural issues around the public health workforce, we really need to have coordinated platforms that look at health, education, and other relevant sectors to sort of plan for that public health workforce, and those are currently lacking. I also think the global level has a lot to do in this space. WHO is currently working on establishing norms and standards for the public health workforce with support from the US CDC, but I suspect it will take a while for that to come out. And I think also so many countries seem to be looking for guidance about how do we best organize our public health system, what kind of profile of health workers do we need, how many should be sitting at the national level, how many at local or district levels, and none of that really exists at this point. So fairly rapidly. The third theme I had wanted to look at was institutionalizing successful innovation in service delivery. And I think we have seen a lot of different innovations in service delivery, and I've put a few of them here. Firstly, the scale up of different forms of mHealth or telemedicine, which we've seen across multiple countries. So teleconsultations were widely adopted, I suspect here too. I don't know, but as a means to prevent sort of face-to-face interactions whilst sustaining health services. And often that came along with a whole slew of regulatory reforms around telemedicine. Many countries had regulations that made it hard to provide teleconsultations or hard to reimburse through insurance schemes for teleconsultations. And that has those have changed very rapidly. And I think taking stock of how they've changed and how effective those have been will be important. And I think we've also seen in many countries a big upswing in terms of self-monitoring and self-reporting of chronic health conditions, so that patients are more and more being expected to track their own conditions, report it, and then seek care when needed. We also saw, and this is going back to the Exemplars in Global Health project, adaptations to protocols to maintain continuity of care while minimizing unnecessary interactions with the health systems. So across many countries, we saw things like prescriptions of drugs for much longer durations. So instead of asking a patient to go back every 2 weeks or every month, they were given sort of drugs for several months at a time. We saw the home delivery of drugs in multiple countries. And then Thailand had this particular model around stratifying its non-communicable disease patients according to the extent to which their condition was under controlled, which they called the new normal model. And I'll speak to that in a minute. And then thirdly, I wanted to reflect on community engagement. I think that during the pandemic, there was increased use of sort of non-traditional venues for providing health services. So using people's homes, open spaces within communities for essential services such as immunization. And in some contexts, Thailand in particular, we saw increased use of sort of frontline health workers, community health workers, to try and follow up on NCD care and other services that they weren't accustomed to providing. This is just the Thailand new normal model. And you can see that it talked about three things: patient risk stratification, so that it grouped patients with NCDs into different groups according to the extent to which their conditions were under control. And then it adjusted the frequency with which they were interacting with the health system accordingly. They also developed these shared care plans that clearly laid out what were patient care responsibilities versus facility responsibilities. And then they employed digital solutions and community engagement, as well as village health volunteers to try and track what was going on with these patients. So I think these kind of models bear significant promise. We've obviously seen some challenges in terms of these kind of innovations. I would refer firstly to concerns about equity implications. Often these sort of telemedicine approaches often seem less accessible to less educated, older populations, maybe poorer populations. Concerns about the quality of care in some of these new modalities, although I think, to be honest, the evidence about how has telemedicine affected, or how have these more sort of remote approaches to delivering NCD care, how have they affected quality? We lack evidence on that right now. And then one thing which we found interesting was that in a number of the countries that we looked at for the Exemplars in Global Health project, even where they had strong primary healthcare systems, they felt that the COVID-19 response had been very much driven by hospital sort of models, and that there had been very weak linkages between the sort of COVID-19 response and frontline health workers. Thailand was an obvious exception to that, but elsewhere there was a problem in that regard. So implications in terms of these sort of new service delivery models, I think we need more research to assess the implications of some of these interventions, and particularly how they affect vulnerable populations. And I think we also need to reflect on how successful some of these models have been in terms of ensuring and improving continuity of care and more patient-centered care, particularly some of the NCD models, and whether they are worth rolling out beyond the sort of pandemic era. And then even in countries with strong primary care systems, I've said this linkage between the hospital system and the primary care system seemed to be a problem during the pandemic. And I think reflecting on how do we strengthen referrals up and down the health system, as well as sort of use of shared information system, including electronic health records. So I've been rushing a little bit just to try and get to the end of this and to give you some time for reactions and questions if you have them. In terms of conclusions, I would say that COVID-19 really stress tested health systems across the world. And I feel like we're just beginning to take stock of what have we learned from this sort of COVID era. You'll probably be aware of the independent panel review that was conducted and led by Ellen Sirleaf-Johnson and Mary Robinson. That was done, about sort of 12 months into the pandemic. So I think it was quite early in that process. And their recommendations focus very much on the global level. I think that we need more country level post-action reviews, and Thailand has actually done this already to take stock of, well, how did we react to the pandemic? What were the lessons learned? How should we be responding going forward? So I offer these likely lessons with a big caveat. This is some of the takeaways that I have from the past few years, but I think it's most important that countries take lessons of their own. Firstly, reflecting on this sort of high-level political leadership for public health. One of the big challenges with outbreaks and disease surveillance and response and emergency preparedness is that we see these boom and bust cycles. When there's a pandemic or an outbreak, everyone pays attention. As soon as it goes away, people turn to other things. So how do we sustain that political interest for longer periods and build and also continue to build stronger linkages with the private sector, stronger linkages between government and research entities, as well as platforms for multisectoral collaboration. I think that there are a lot of questions around public health systems and developing robust public health systems with trained human resources, establishing standards and best practices for public health, identifying human resource needs and norms, rolling out training that really responds to some of the challenges that we've encountered during COVID-19, such as misinformation, politically charged environments, as well as streamlining and paying attention to these disease reporting systems. And then I touched last upon these sort of innovations that occurred during the pandemic, looking at extending or taking stock of mHealth and teleconsultations and how we might build upon what's happened there, as well as some of these new models of NCD care. Finally, I think that there is an interesting and important agenda for researchers in terms of thinking about what happened during the pandemic and assessing how effective it was for more sort of day-to-day health systems, as well as for future pandemics. I've identified two areas where I think research is really needed. Firstly, around looking at the equity and quality implications of some of these innovations that occurred in service delivery, but also thinking about standards for the public health workforce and what kinds of structures and systems of public health work better and in what contexts. So I've run over slightly and I apologize for that, but hopefully there's enough there to stimulate some reactions.
Thank you, Dr. Bennett. Now the floor will be open for questions. For our friends on Zoom, please write your questions in the chat box and I will read them for Dr. Bennett. And if you have any questions, please state your names and affiliation so that Dr. Bennett could identify you also. Any questions?
Thank you, Dr. Bennett. I think this was a quite interesting, informative presentation. Just more of a brief reflection. I would like, I'm sure there are many questions to be asked, but some of the findings that you've already presented is quite, interesting and enlightening and informative. And in fact, some of the intervention that we have seen and evaluated in our region we actually landed on something similar to what you already have. So it looks like there are some cross-cutting lessons, globally in terms of how government responded. But certainly, what I've learned as well, and what we're seeing in our region, that many governments have made the wrong political choice of not investing in public health system, and this was really what we have learned during the COVID-19. I think the challenge is of how, and we're hearing a lot about the lessons learned. The worry we have, because crises are opportunities for change or a missed opportunities, and we thought there are opportunities for change, at least for some governments. And now we're starting to feel that there might be a missed opportunity, because we've seen a high, there was a lot of interest in public health, just because everybody was in the same boat and we need to respond. And now the interest, because of particularly a country like Lebanon and others, we have a lot of overlapping crises. Priorities change. The question is, what do we need to do to engage with political forces in order to make sure that public health stay on the agenda of government, but also to have clear actions being taken in order to institutionalize those lessons learned. So, because the question is not really whether we're going to have a new pandemic or not. It's a question of when we're going to have the next pandemic, or when we're going to have the next shock or crisis. So I think that's a challenge of what we already face, particularly as academician, that in that sense. You might hear other questions, and then maybe you can ask Dr. Bennett.
Good idea.
Thank you very much for a very interesting lecture, and actually I take up from what Fadi mentioned. I think, in fact, if you want to really be a little bit philosophical about it, the public health system in any country gained a great deal of strength because of it showed how important it is. And in fact,
Okay, we have one more question also from, hold on, from Jade Khalifi from Lund University in Sweden. Disease transmission is a critical lesson during a pandemic. For COVID-19, this means clean air to prevent airborne transmission, better indoor ventilation and masking. So first question is, why are most health systems neglecting these measures and the public health purpose of prevention? Second question is, how can health systems be engaged on this? We have lots of questions, so I don't know if you would like to start answering, and then we will get back to the questions. One more from Dr.
Thank you, Dr. Bennett. This was comprehensive, quite informative. What I missed in the presentation is the whole issue of the social stressors that actually accompanied the pandemic. And so we all know that in the first phase of the pandemic, people were ready to engage, and then when their livelihood was threatened, they turned against even the public health system. So did you have spent of whether the systems or the countries that you consider successful have addressed this also in a satisfactory way? So
yeah. Thank you very much. Those were all really interesting and excellent questions. And to a certain extent, a little bit existential. I mean, this question about how do we engage political forces and make sure that they stay focused. I don't think there's an easy answer to it. I think one thing that we have discussed with a number of the National Public Health Institutes that we're working with is that there remains a lot of confusion amongst politicians and policymakers as to what a public health function is, how it operates, and even being able to sort of tell some of the success stories of the pandemic is something that, you know, we've been talking with them. Well, maybe you need a strategic communications campaign that really talks about the role of the public health during the pandemic and what was accomplished, to just make it clearer. But I suspect that alone is not going to be sufficient, and what we really need is you know, a more broad public knowledge around what public health is. And I honestly don't have good suggestions about where to start that. It does tie, I think, to this question about the role of the media. I would totally agree with the observation that the media was critical and both positive and negative. We certainly saw that in terms of Uttar Pradesh, where we were working. I think that there are things that can be done to better harness the power of the media. So I referred very briefly to Sri Lanka, where they had actually been trying to provide training to public health workers to better engage with the media during COVID-19. I know our DRPH and to a lesser extent our MPH have sort of communications modules which include things like speaking to the media. But I think that that is something that we need to think more about, given how important you know, communications is, and to strengthen that element of the training that we provide. And then the question from the person online about you know, paying attention to issues such as clean air, or I was thinking more broadly sort of some of the social determinants that affect public health. I guess a personal reflection is that I feel like health systems rely tend to start to have a core focus upon personal healthcare services. When they do extend beyond that, they're still thinking about things which are very close to health. And we've traditionally not been good at engaging multisectorally to address some of the broader social determinants, whether that's to do with clean air, clean water, you know, commercial determinants of health. All of those factors, I think that we have neglected for too long, and need to be a much stronger focus in terms of what we're doing. And I think again, it speaks a little bit to the kind of skill sets that public health people have. And engaging across sectors is something which is often people find quite challenging. That speaks a little bit to the last question about sort of social stressors. In terms of the countries that we looked at, so we went out of our way to avoid countries that had, in terms of our exemplars, that had very successful and very rigorous campaigns to prevent the spread of COVID-19. One of the things we recognized was that in terms of selecting countries, we needed to have countries where there had been some impact of COVID-19 on the country in order to be able to see what kind of strategies they had used to sustain essential health services. So most of the places that we were looking at had, you know, lockdowns and things like that, but for relatively brief periods. It wasn't the sort of situation of China where you had, you know, a very robust lockdowns. But we hadn't looked at that question in particular, and I think it is an important one that needs to be included in terms of these reflections. And it goes back more broadly to sort of recognizing the links between social determinants, and, you know, we may prevent the spread of COVID-19, but if we're stopping people from earning an income and feeding their families, that's clearly problematic. You mind speaking up a little bit? I don't think the microphone is working and I'm having a little difficulty hearing you. Oh, it is working maybe. Mhm.
I think if the second issue has to do with directing funding to this sector. Because what I realized from the Ghana context was that we had close to about 5 state researchers that have the capacity of that test, but from nowhere, an international testing agency was cited at the airport to conduct COVID-19 test. Nobody knows where the money was going to. And at the end of the day, the research institute were left behind. The quality is still very good. I think we can also look at certain state evidence of some financial support, international interest. How do we engage the Thank you.
Yeah.
Thank you, Dr. Bennett. Maybe I have a comment rather than a question. So in COVID-19 specifically, it was more, not more, but as much as it is a health system approach, but also it was a population-based approach. The behavior of the population was quite important. So I'm just thinking loud about whether you looked at this link between the government, behavior of the population. What are the criteria which the population implement the directives of the governments in this sense? I'm talking here about, for example, issues like trust, and what criteria would be some criteria which could be present before even the pandemic. Such kind of maybe social determinants of health, political determinants of health, and other criteria.
Thank you. Should I try and do you have more online? Oh gosh.
Chat box from Gladys Hnain from the School of Nursing. She's particularly interested in the NCD Thailand model. She thinks it has potential in our country, but given we are highly privatized system, the reimbursement is an issue. Any advice and comment on this particular issue? And the last question from Maya Fakhri, a research associate at the Faculty of Medicine at AUB. What we have learned about the best targeted therapeutic regimen for COVID-19 and that targets as well the long-term side effects.
Okay, a lot of diverse questions, some of which I think are outside of my sphere of knowledge, and I might sidestep some of them. Going back to Kelvin's question first about the source of information for vulnerable populations. I mean, I think that varies from context to context, but just reflecting on Uttar Pradesh, where we were working, it was clear that vulnerable populations were getting their information primarily from social media and from networks. And in particular, these networks, sort of informal providers in village, so sometimes called quacks. So not reliable sources of information. And I think that is a particular problem. And if I understood your second comment, Calvin, it was about the fact that the sort of some of the research institutions which did have the capacity were not fully involved in terms of the response. And I think that you know, we saw variability in that, but recognize that where solid research institutions were involved in the response, by and large, that worked better. In terms of your question about the sort of behavioral characteristics and were there issues about the nature of the government that helped people respond better, it wasn't something that we set out to look at, but I do think that this issue of whether the government had previously dealt with outbreaks and how effectively they had dealt with them was one thing, so sort of established reputation in that field. So Thailand, for example, I think again you could see as a successful country which had obviously dealt with outbreaks of avian flu as well as other conditions previously, and the population did follow the kind of guidance that was issued, but it wasn't something that we had clearly looked at. There was work that Peter Berman was leading out of the University of British Columbia, which was looking much more at some of sort of these issues around governance and sort of soft aspects of governance and how that influenced the response that may address that question. In terms of the NCD model in Thailand, the question from Gladys, I would have thought that potentially that is something that private insurers or insurance agencies might be willing to look at and take up, in the sense that I think those kind of models that the Thai government was experimenting with would have also driven costs lower as well. And as insurers are worried about their bottom line, that might be something that was relevant. For the last question from Maya, I'm going to leave that one because I don't think I am qualified to talk about the sort of therapeutic regimes for COVID-19, but good question.
Okay, so if there's no more questions, I think we have one last question. Hello? Yeah. For a lot of patients, especially in China, are students using the ruler non-licensed medical practitioners, and a lot of the Indian population that has migrated outside to earn money and send back have no source of income. A lot of countries stop paying their workers, especially the ones that are using Pilates in the Middle East. So why would the Indian government, what were the drawbacks that the Indian government saw with working with these rulers, non-licensed practitioners, that made them leave out a large portion of their own vulnerable population without any aid and without any care?
Yeah. It's a great question. It's a great question in the sense that it's something that we've been trying to work on and largely unsuccessfully. Yes. Sorry, the question was, as I described in the Indian context, a lot of the poorer and more vulnerable populations were reliant upon these unqualified rural medical practitioners, and yet government was unwilling to work with them, even in terms of providing clinical guidance or anything like that during COVID-19. How do you explain that? I think the best way of explaining it is that India currently has quite an ambitious set of health policies called sort of Ayushman Bharat, which is about scaling up government primary healthcare services and about providing insurance particularly to poorer populations. And governments in most states, not all, but in most states, are sort of unwilling to acknowledge the size and significance of the private sector because it's seen as a kind of failing of the government sector, which in many regards it is. And so it's a political decision not to work with those providers. And yet, as you rightly point out, they provide essential services, probably for the majority of people in rural areas. Things are slowly changing in terms of government primary care facilities, but by and large, about 70%, 75% of outpatient contacts in India are with private providers and typically those kind of providers. So it's a shortcoming on the government side.
Okay. We're out of time. So Dr. Bennett, thank you for this wonderful talk. I don't know if you have any last words to say.
I don't think so. Just thank you very much for coming. It's been a pleasure to talk with you all, and I hope we have more opportunities to interact.
Great. Thank you.